Today on the EMTS Academy Podcast, I'm joined by Dr. Taylor Ratcliff. He's the medical director for multiple EMS agencies in Texas, including Williamson County EMS, Falls Area EMS, Robertson County EMS, and the Texas Emergency Medical Task Force Region 7. He's also an associate medical director for Travis County Starflight. Dr. Ratcliff is a former firefighter and paramedic from Lubbock, Texas. We discuss how an EMS background can help during medical school, how the Texas model of disaster response is being adopted nationwide, and what the world of EMS may look like in 10 years. If you're an EMT, paramedic, or EMS leader who wants to expand your understanding of the EMS landscape, this episode is for you. Let's get to it. Dr. Ratcliff, thank you so much for joining us on the podcast today.
Thanks for inviting me, Matt. You've had some really important guests so far that I need to compete with. So I'm glad I get the chance to talk and not just people like Jeff Jarvis.
Yeah, well, I hope you brought your A game today. I hope you're going to bring it.
A something, maybe an A minus. We'll try.
Well, you have an interesting background starting in Lubbock. Before I get into that, I want to ask you a kind of personal question. I just started reading a book called The Birth Order Book. And this guy has a philosophy that where you are in the children's stack determines how you act. So I want to see, just out of curiosity, brothers and sisters?
One brother, younger.
So you're the oldest?
I am.
Do you think that has had an impact on what you did as a career?
Well, it's an interesting question. I've never thought about it. The interesting thing about my brother, Evan, and I, and he's in law enforcement, actually, we both became paramedics, and then I kind of went the fire route and he went the law enforcement route. But we're 7.5 years apart, so I don't know that we had as much influence on each other's ecosystems as kids that are a year or two apart, if that makes sense.
Yeah, it totally does. He talks about if there's more than 5 years apart, that he is also kind of a firstborn, and what he calls a new family. So interesting dynamics there.
I think
just
that's
getting
true.
into it. So I don't know how much validity is to, I think anecdotally from the things I've seen, I think there is something to that. So you started in Lubbock, and tell me about that. You became an EMT and then a firefighter, or firefighter then an EMT?
Yeah, it was actually kind of a weird story. And I mean, I think we have enough time to talk and unpack some stuff. So
yeah,
the weird thing is all my life, I don't know, for some reason, I thought I wanted to be a doctor. And that permeated through high school. And I was in some kind of a United Way leadership group. And so we were having a meeting and they were setting up a career day and things. I think you and I are contemporary. So stuff had come out that some of your listeners will be like, I'm going to have to go Google that, Rescue 911.
Yes.
Some of the old shows. And I was super interested in all that. And so I said, I want to shadow a trauma surgeon. And they came back, and trauma surgeons are busy, and sometimes they are not the most social people as we sometimes. And so they said, well, we couldn't find a trauma surgeon, but we found these EMS guys. They do trauma. They didn't know what they didn't really know. And they said, do you want to go ride with them? And I said, well, I've never been on an ambulance. That might be cool. And remember, I'm 15, right? And Matt, we had a crazy shift. Like I didn't know anything about anything, but they did a trauma arrest with a surgical airway. We had a STEMI. We had all the range of little old lady fall down problems. It was just pretty crazy. And I left hanging out with them and super energized. It was crazy. I loved it. It was this mashup of medicine and adrenaline and all the things that I'm sure you loved about it too. And interestingly enough, I called out a guy named Alvin Chapman, and his partner was David Harbour. David actually wound up in Alaska as a bush medic, actually. You may have crossed paths with him at some point. But I called Alvin because he gave me his number. I said, how do I do this? And he said, well, I happen to run the Medical Explorer post. And so I became an EMS Explorer. And that was pretty cool. And so I had my EMT before high school really was over. And then roundabout issue, I went away for college, wound up getting hurt playing sports and came back. And I conned my parents into letting me go to paramedic school while I was recovering. And they were terrified that I would never complete my education. But anyway, so I went to paramedic school. And then this was an interesting piece too. I was too young to get on the insurance to drive the ambulance in Lubbock. And so they told me that they would hire me, but they made me work in our 911 dispatch center as an emergency telecommunicator first until I turned 21, which was about a year. So that was actually a good experience because it gave me an appreciation for what our emergency telecommunicators do. And then, I started on the ambulance, and it was just a whirlwind. It was a normal career. Lubbock, even though it's in the middle of nowhere, is a really busy place, high acuity. I ran dual medic at the time, very progressive protocols. And interestingly enough, after 5 or 6 years, getting married, having a kid, maybe was beginning to feel some burnout and really started looking at long-term career longevity, things like that, pension, promotional structure, ladder, all those things that sometimes EMS struggles with. And that's when I crossed over to the fire service. So I had to work a couple of years to get that done, but I got pretty lucky and got on with the Lubbock Fire Department the year after 9/11. And then the rest was kind of history. The road to medical school kind of started then. We can talk about that if you want to, but yeah, that's kind of how my career went.
I sat next to you at dinner one time and you were telling me the story. And I think there was a fork in the road while you were at the fire department working that basically led you to medical school. Am I remembering that correctly?
Yeah, you got a great brain for that. That was good, Matt. Yeah, so what really happened is after my rookie year, they asked me to run the medical first responder program for the fire department, which also meant that they moved me to a working fire station, but it was more out in the admin area. It was really slow. And I was so bored at night that I had some MCAT books, and I started reading MCAT books at night when I was at the fire station every third night. And after a while, I was doing some practice tests. It was more of it's very geeky to say a hobby. I'm glad Jarvis has been on before me. But anyway, just kidding, Jeff. Love you. But eventually I've scored pretty well on some of those. And I talked to my wife. I said, I guess I'm just going to go take the MCAT and see what happens. And she said, well, yeah, it didn't cost that much money. And she said, just go try it. And so I went and took the MCAT and I did okay. It was kind of middle of the road. It wasn't bad, wasn't good. And that whole process was interesting because at the time, my father had already passed away and my mother was not very healthy. So we needed to stay and take care of her in Lubbock. And this is for all of your listeners that are headed to med school or have gone to medical school, they're going to throw things at the screen now. But I talked to my wife and we hatched this harebrained plan that I was just going to apply to Texas Tech one time. And if I got in, great. And if I didn't, I was going to be a firefighter and a paramedic the rest of my life and be happy about it. And for some reason, that all lined up and Texas Tech took me. It was wild.
How did being a paramedic either help or hurt you during medical school?
Oh, that's a very loaded question. And I'm sorry, I know we're not supposed to time these things, but it is cedar season as we're recording this. So I'm dying here. It's for all of you that don't live in Central Texas, just be happy that you're not here right now. Just read about cedar fever. But well, it was really interesting because it was really frustrating. And for the people that are headed to medical school or want to go, this is important for them to know, Matt. It's the first couple of years has really nothing to do with real clinical medicine, which is very frustrating. Mm-hmm. So it was more frustrating to me as a paramedic because everything that I knew, everything that I'd taken in undergrad, everything that I learned over at that point, probably close to 10 years as a paramedic, we blew past in the first 2 weeks of every different discipline, whether it was biology-based or anatomy or whatever it was. Everything that I'd learned in life to that point was gone after 2 weeks. But then I remember this in particular, we were doing pathophys, and one of our professors tried to teach us to read EKGs. Now, a lot of people don't know this either. In some medical schools, you are taught by doctors. In most U.S. medical schools, especially during the first 2 years, you're taught by PhDs. And so they're doctors, but they're PhDs, not doctors of medicine. So I remember this PhD electrophysiologist trying to teach us how to read 12 leads. And it enraged me inside because it was so bad. And I had another paramedic that was in class with me that was a classmate, and he and I talked after that 1 hour lecture, and we emailed our entire med school class and said, hey, we're going to be doing a really how to do this at 6 p.m. today if anybody wants to stay late and actually learn how to read 12 leads. So we had about 100 people come listen. It was fun.
What advice do you have for somebody who may be sitting there on the fence about whether they want to go to medical school? And a lot of medical schools now are requiring at least an EMT certification. What advice would you have for them? Because sometimes they feel like, well, I have to go to EMT school, but I don't want to. I just want to be a regular doctor.
Sure. I think, well, gosh, things are so different now than when I got in. I think people who are trying to go to medical school right now, Matt, are super concerned about everything. So they're concerned about their grades. They're paranoid about their GPA, of course. They've got to do really well on the MCAT to be competitive these days, which is hard, as we all know. But then the schools are really looking at how are you demonstrating that you really are interested in healthcare, right? And a lot of our medical school applicants are going straight through. So they go straight from high school to college and then are doing all those things to try and apply to medical school. And they, I guess, good and bad, haven't really had the opportunity to really invest in seeing what healthcare feels and looks like yet, and have not been able to really to deep dive into providing care for people. So EMT, I think, is a well, that's what's the right way to say this, is a low cost, low risk way for people who are headed in that direction to get a look at what healthcare looks like. The knowledge that they would learn in your program or anybody else's program is certainly just going to help. And even if they never get into medical school, that, I mean, we should probably teach EMT school to everyone in high school. Just
Agreed.
If you're going to be a human on the earth, you probably need to know how to be an EMT.
Yeah, there's that gap, that 6 to 8 minute gap from when you dial 911 until EMS arrives, and knowing what to do. Again, I'd stop the bleed, first aid are good, but having an EMT certification, that information is lightweight and it travels well. And I've been on an airplane when they do is there anybody with medical training? And I'm like, no. And my wife's like, ding.
And you're like, she was just kidding.
Yeah.
Yeah. And so there's that. So, I mean, I think we see a lot of our pre-med matriculants that are looking for an EMT class. And I think they enjoy it. I really do. That's what I hear, versus the medical school program making them be an EMT during that first year of medical school training. And I think those are kind of two different worlds, because when you cross over into that latter part, you've gotten into medical school. Like, you got accepted. You're not still trying to build your resume and your academic portfolio and your research and your shadowing and all the things that they want you to do now. And so I think for some of those students, it seems like a delay, and it seems like, why are you making me do this when really I need to be learning about pathophysiology and the anatomy and all those other things? And what they don't know at the time is that's letting them tiptoe into the waters of an early clinical experience, and on day one develop some very basic life-saving skills, like you just said, to where when they're flying for interviews on the airplane, they at least have some understanding of how that works. But I see both sides of it. The early clinical experience, I think, is really the important piece, whether it's done through EMT or whether the medical school program puts them out in the clinical setting early on. It's frustrating to just learn book things for 2 years and not touch a human when that's what you want to do is healthcare.
Yeah. You are the medical director for many EMS agencies. What are some of the challenges that you face as a medical director? What keeps you up at night?
Oh, well, that's a really long list. Well, actually, I should say this differently. For your listeners that are outside of Texas, we could just kind of talk about delegated practice for a minute. So
Sure.
Texas is really unique. We do not have a large state medical director. We don't have a large state set of protocols or guidelines. We do have a state office of EMS within the Department of State Health Services, and Joe Schmieder is our state EMS director, not medical director, and he's great. We love Joe. But in a lot of states, you have a lot of top-down regulation, and the local medical director is a little bit insulated from making all the decisions and are like a satellite figure, in a manner of speaking, right? Not in Texas. We don't have any of that. So it's true delegated practice. So whatever the Texas physician says and allows their providers to do is what happens. And we could even, I guess, do brain surgery or whatever we could not get over our skis with the lawyers on. So there's a lot, and a lot of people do ask, do you sleep at night because you have people using your medical license to go out and provide care? And my answer is I sleep fine. I really do. Because one is we work with great people. We know that our community, for the most part, wants to help and is intrinsically motivated to do that. And so I know that we have a lot of great people that are going out and trying to do the right thing every day. But we do face challenges, and some things are out of our control. So the overall, we're, and you know this to be true, we're more and more becoming the social healthcare safety net for everybody. And when EMS, let's go all the way back to the late 60s, right? What was EMS started for? We were trained by cardiologists to go get heart attack victims and bring them back to the hospital. We were commissioned by the Department of Transportation at the time to go get trauma victims and bring them back to the hospital. We were built on a culture of being retrievalists. But now we're being asked to reconcile medications, help me with my Medicare application. I need a consultation for mental health care. All these different things that we're being asked to do, social navigators of the healthcare system. That's part of that keeps me up in the sense, Matt, that our core training and discipline is not keeping pace with what the world is asking us to do, if that makes sense.
Yeah, 100%. I think that we should move away from the word EMS, emergency medical services, and instead, it sounds really weird, PMS, pre-hospital medical services, or something like that, right?
You're going to need to wordsmith that one a little bit.
Yeah, for sure. We can work on that. But pre-hospital medical services is more descriptive of what we do. It's outside the hospital. OHS, I don't know. There's something else that describes what we do a lot better than just emergency.
Yeah, you're right. And we were actually talking about this today. We had some budget meetings today, and it truly generates different competing priorities for us, right? We still have to be really good at that emergency part when somebody really has a terrible trauma or a heart attack or stroke or whatever that is. We still have to be good at the emergency healthcare piece, but we've also got to figure out how to allocate resources to harm reduction and social navigation and all the other stuff, because it's just not for everybody that's working in industry. You've taken a patient to the ER in the last 3 months and you've been asked to hold the wall because there's no beds. So we have to be part of the solution of developing an infrastructure and a process and a discipline where not everybody goes to the hospital just because they called 911. So that keeps me up a little bit. The other thing, I guess, and I know this is part of what you talk about quite a bit, is making sure that the data systems and tools that we're building today are the right ones for the young people coming into our workforce. And so things like how we train, how we write protocols, how they want to consume data and retain data, decision support tools that we make, all those things, that gives me pause because I'm not sure that we have the right answer, and we need help with that. So
yeah, I think when you and I were young in college, young paramedics, there were only a few channels to communicate on, right? You had a radio, you had maybe a cell phone, and you had maybe the fundamentals of email. But now there's Slack, there's text, there's phone call, there's Pulsera, there's every different way to communicate. And that can be really hard because if you're trying to communicate to your staff and get them information, what's the right channel and what at the right time? So, yeah.
Well, and we had that big printed protocol book, right?
Yeah.
It probably had some blood and vomit on it somewhere and it's a little bit gross. But still, when you started that, you slept with that thing because you knew you had to know everything in that book, because it wasn't just as easy as typing in adenosine into your app and it tells you everything you need to know about the drug. So, so those are some of the things that are on my brain. Do what?
We had it memorized, right? I mean, we knew it. But yeah, now you can say, what's my dose for oxytocin or what have you? So, yeah.
And I'm not sure which one's better, right? I mean, it's just the evolution of what we do, I guess.
Yeah, absolutely. You are the medical director for the Texas Emergency Medical Task Force, EMTF. Tell us a little bit about that. And that's for District 7, is that right? Or Region 7?
Yeah, Region 7. That's right. So, yeah, the Texas Emergency Medical Task Force, or we'll just call it EMTF, or else we'll run out of time, right?
Yeah.
Key leaders in Texas built that program after Hurricane Katrina. That was really kind of the impetus for building what our current structure is today. And by the way, everybody that lives in Texas can be very proud. It is a model that is looked at nationally. There are many states and frankly, even the federal government that are building some of their disaster readiness medical programs based on the EMTF program. So everybody that works with the program and helped build it can be very proud. But the issue was, and this is basic emergency management, right? So if some of your listeners haven't heard this saying, they need to learn it, right? All emergencies begin and end locally. And you'll hear Chief Nim Kidd say that. He has that probably on a business card somewhere. I don't know. But so there are things that happen at the local level that through local response, mutual aid, you can handle. We're very blessed that today I'm in Williamson County, and just to our south, we have Travis County. So between our organization, our friends in Georgetown, and then all of our partners down in Travis County, Austin EMS, we can mobilize 50 ambulances just kind of like that. So our ability to deal with a moderate size incident here, for example, is probably going to be pulled off with local and mutual aid. And then go all the way to the top, there's federal aid from FEMA, but we know that that animal, much like spinning up the helicopter, right, takes time to get it going. So the problem with that is that there's going to be somewhere between a 72-hour to a 96-hour gap in between activating the federal system until we actually get federal assistance boots on the ground operating and helping in our area. So that's really where EMTF comes in. And the EMTF program was built to be a bridge or a step in between local response and federal response in our state.
So the EMTFs, they have strike teams of groups of ambulances that could deploy and nurses and things like that. Is that right?
Yeah, the interesting thing about EMTF is its original core function was disaster response in our state, right? So what the founders built out was the core concepts of ambulance strike teams. Because, and you remember some things before EMTF, we could mobilize ambulances to disasters, but they were not as coordinated as what we would have liked. So a little haphazard, right? So EMTF really dialed that in. Ambulance strike teams, along with that, ambulance staging manager certifications. But to go with that, basically the AMBUS network. And so if your listeners haven't heard, an AMBUS is exactly what it sounds like. It is an ambulance bus or a multi-patient vehicle that can transport a large number of evacuees or injured people or whatever that is. And then along with that, another core concept of the mobile medical units, which is basically just a field hospital, a forward field hospital. And the whole concept was that we push the MMUs forward with doctors, nurses, APPs, paramedics, all working in a kind of an austere tent environment with basically ER capability to stabilize people, handle problems that people can be sent back home with. Hey, my medicine got washed away. Okay, here's refills on your medicine. You can go back home, basic suturing, all that. Or if we needed to evacuate people, leverage the ambulance strike team system or the AMBUS system to get them out. And then along the way, EMTF became this Swiss Army knife where the structure worked for building solutions to other problems. So the next one that really came around, and I'm probably getting the chronology wrong, but do you remember the Dallas-Fort Worth area infectious disease case, right? Where the patient had Ebola.
Yeah.
And so the state, in response to meetings with other partners, said we really need a mechanism to have specialty transport for high consequence infectious disease patients. So we built out basically an infectious disease response unit where the hospital-based team was trained to go to the affected facility and help them take care of this person, being very skilled in HCID response, right? And then there was a specialized transport network that would very securely come get the person. And we had a plan to move them to a biocontainment unit where they could be properly cared for. So things started to happen like that. And then Hurricane Harvey hit. Harvey was really kind of our first Super Bowl game for the EMTF program. And like anything else, the plan after first contact gets changed, right? And so we continued to build out other things. The teamwork, that's our fatality management teams for decedent care. That was huge during COVID, unfortunately. Our air medical wing, so basically an ambulance strike team, but for helicopters and fixed wings. One of the big ones lately is we have wildland fire medical support. So the wildland has been a big issue in the state in the last several years in particular. And so we partner with Texas Forestry Service and our other firefighting partners to try and be their medical backbone to make sure that they're safe and we can take care of them if they have any needs. And so there's a tactical component, a variety of different things. So we've just continued to sort of do that hub and spoke concept where we've built out other needs based on the EMTF structure. And the structure is that we have 8 EMTF regions all across the state, with our 9th office really being the state coordinating office. But it just works really well because we get together and we train. It's modular like a transformer. If we have a small incident, it may just be one EMTF team. If it's a large incident, it may be all 8 coming together to work together. And it's really cool. And in a way, it's kind of the purest form of pre-hospital medicine because there's minimal bureaucracy, red tape. It's just really you and your team taking care of the patients. It's really fun.
That's really great. I imagine in my head a group of Legos, like you have 4 little ambulances as a strike team, and then you've got the little people, and you can call whatever you need. And it's almost like one of those little 6-packs of here's a 6-pack of ambulance or a 5-pack of nurses, that type of thing. So that's really great.
That's exactly what it is. And to your point, I left out one of the major components, which is our MIST teams, medical incident support technicians, I guess. And imagine them being like the forward observers. The MIST folks usually get activated very early and they go to the local affected jurisdiction And depending on whether their discipline specialty is inpatient or hospital medicine versus pre-hospital, they're going to go, maybe a hospital has lost power and needs to be evacuated. So they're going to go rendezvous, figure out what their needs are, how many patients, where they're all going to go. It's the pre-planning arm of the EMTF program. They're really important too.
Kind of like a military scout going ahead and saying, here's what we have and here's what we need.
That's exactly what it is. Yeah.
Yeah, that's great. Dr. Ratcliff, what is your proudest accomplishment so far?
Oh, gosh. Well, my family. You have to say your family, right?
You don't have to. A lot of people will, but not everybody.
Yeah. I mean, well, I guess in case, yeah, it's appropriate. So, no, my family is, of course, my proudest achievement, I face. But from an occupational standpoint, it's interesting that I'm very thankful. I'm trying to say this the right way. I'm very thankful that I got to be here. I am proud that I had the opportunity to come be here. Because when you're starting medical school as a former paramedic firefighter, and really the only reason that you want to do it is to become an EMS physician, the fact that you actually got through and got to be an EMS physician is what I'm thrilled about. And so I take a lot of pride in getting to have some trust and in people allowing me to help them be EMS providers. And I try and use I've tried to use a football analogy before to kind of what we do, right? There's your team owner, that's the company. The head coach is probably the director. And then what am I? Where do I fit into the whole thing? Well, I'm kind of like one of the line coaches, right? Maybe I'm the offensive line coach. I don't know. But it's fun to get to be part of the team. And I am very proud of for lack of a term, our players, all of our practitioners and providers out there that are doing the good work. It's really fulfilling to know that we can have some impact on the hundreds of thousands of touches that our providers go out and make every day. So it's really cool. I'm proud of a lot of things. I'm proud of our agencies. I'm proud of the EMTF program. I am so proud of our state taking an aggressive stance on emergency management, emergency preparedness, and pre-hospital care. To talk about blood, amazing. Yeah. When you and I were working, I mean, maybe at some point you were like, man, I wish I had some blood. But to bring that to fruition and understand that with this $10 million that the legislature's given us and what's already happened in our state, that in a couple of years, you probably, if you get hurt badly in the state of Texas, you will probably have access to blood. And that's really cool. I'm very proud of our team making that happen. So yeah, it's hard to even zone in on. There's so many things that are great that are happening right now.
Yeah. Steve Jobs said something, I can't remember it right now, but he said there's always an intersection, and that's what it was, technology and art. And I think you have this amazing ability as a former firefighter, paramedic. You have this side of it. It's almost like a double helix. And then you went to medical school. So it's like this double helix rotating still around medicine, but you understand it. Like when I started in EMS, medical doctors were not involved. I think Dr. Rock being on the cover of the GEMS magazine back in like May of 99 brought me to Austin. It was like, wait, a medical director who actually has a first response vehicle and goes and out and responds on calls. I think that's amazing. And so I'm really proud. I like to see that part of EMS. The fact that, like you're still out there running calls, you're out there, you know who the crews are, their strengths and weaknesses. And that's very impressive.
Well, and thank you for mentioning that, Matt. I think we are getting into the EMS physician community conversation for a second. I think we stand on the shoulders of those that came before us, right? Dr. Hagedorn, Dr. Fred Hagedorn was my first medical director, and we were friends, and he was pleased that I went to medical school, and actually he got to teach me some. But right, those guys weren't paramedics. Unless they intentionally went out and did it, they didn't necessarily go out in the field. They taught us good medicine, and they helped write good protocols, and they gave us good counsel when we needed it, but it was just different. And now you've got this neat generation of folks that had the opportunity to be EMS providers in the field and then got lucky enough to go on to physician medicine. It just makes it, I don't know what the corollary is. It's like running a company that manufactures cars and you've never driven a car in your life. What do the consumers want? Well, I don't know. I've never driven a car. I don't have a driver's license. So I like it a lot. And I think it's really neat. That's where the profession seems to be going.
Mm-hmm. Yeah.
And I'll tell you, I'll make a positive statement. What we have to get rid of is medical directors that are not involved. If medical directors are not involved with their agencies and they are not contributing to protocol development, helping with their QA, QI, doing some teaching. And now, granted, I don't want to get yelled at. There are some medical directors that are volunteer medical directors in small communities that are still running their clinic practice and rounding on patients in the hospital. And God bless them because they're giving everything that they can. But there's also people that are intentionally out there just collecting a check and are not involved, and we need to get rid of them. So
Yeah. Physician by name only and no
exactly,
involvement. Yeah, I agree.
the milk carton medical director.
Yeah. If they go missing on the back of a milk carton, nobody will know who they are or where
That's
they've
right.
been. Yeah, absolutely. Imagine that we're 10 years out from now. What does EMS look like? How do you see AI changing that? And what do we do to make EMS even better?
Oh, 10 years is, I mean, it's hard for me to even envision. I think, did you help or give any comment writing the EMS 2050
Mm-mm.
project? I think it's interesting and it would be fun to go back and read that. I think we shortchanged ourselves, to be honest. I think it's going to be even wilder than we thought.
Mm-hmm.
So 10 years. Okay. So I think in 10 years, a bunch of different things. I think that our programs where I think we're going to be a lot better at handling all the components of pre-hospital care, like we kind of started off with. I think we're going to have much more robust community input, help with the healthcare navigation, treat in place, be a partner in providing healthcare in the home. Because I always kind of ask them, like, why are we different than home health, right? I mean, that's been around a long time.
Yeah.
Like, why are we different than home health? Well, there's a big difference between us and home health. Number one is with delegated practice, we can practice independently. We can think independently. We can make the decisions of a practitioner, a provider, a physician, and act like a provider, a paramedic, a nurse, whatever. And so we can think, evaluate, and do things in the home. And oh, by the way, guess what? We don't go clock out at 5 p.m. and go home. So
Yeah.
to me, that's the big difference. We're always going to fill that role, and I think have an expanding role. And will there always be a need for home health? Yes, of course. But we need to be the on-demand acute care option for things that maybe don't need 911 to go to the hospital, but need something in the home. So I think the partnership, I think it's going to be really cool to leverage the technology. There will be something cool that will have happened and expand on what's going on right now with the facilitated telemedicine.
Mm-hmm.
And so I think that you'll have paramedics practicing independently, but also you'll have a situation where, especially in the home, physicians and APPs are doing facilitated telemedicine via even better audiovisual interfaces. Who knows, maybe it's even a hologram or something where we appear as a hologram in the home, and connectivity is going to be better where you're not missing every other word on the phone. And you'll have bandwidth for these data streams that will be sending diagnostic information to you sitting wherever you are, helping the EMS provider do facilitated telemedicine, right? AI decision support tools are going to get better. I think that ambulances, I mean, I know there's models already, demos, but your ambulance will listen to you. So your ambulance will have some integrated AI that as you're talking to the patient and doing things, it's able to take in the streams of your clinical informatics, what your monitor's reading and detecting, what your partner's doing, what the patient is saying, how they look. I think your listeners have probably seen this. There's an app called Good Sam, and it's not the car club, right? Or the RV club, where you can point your phone at the victim and it can tell you what their heart rate and respiratory rate is, right? So in 10 years, the guy's going to be saying lethal rhythm detected, and you're going to look over at your monitor and they're going to be in a run of VTAC, right? And this would be a huge crowd pleaser, and I think this is coming. AI is going to write your report for you. So it's going to be somehow with you in the home. I don't know if that's body cameras or whatever that is, wearable. And then when you get in the ambulance, it's going to switch over and it's going to take in all the information from your ambulance. You're going to be talking to your patient. We're already doing this in the ER. And by the time you get back to the station, it's going to have the rough framework of your report written, and you're going to make sure it's all correct and add the information that it didn't get right and send it on. So I just think it's going to be really neat. I think the clinical decision support tool, I don't know, I guess we have to make a name for it maybe. We'll call it Henry. I don't know. Henry, what dose of adenosine should I give this patient? Well, I can sense that the patient weighs 67 kilograms. You should give I don't know. I mean, I think we're going to see wild things within 10 years. And then not to mention response. So definitely for scarce resources like blood, drone delivery of scarce resources is going to be huge, I think. And I think we just know drones are going to get faster. They're going to be able to carry heavier payloads. And then have you seen the autonomous single provider drone yet that you can get in and ride in?
No. Is that like the Jetson One kind of thing?
It is, yeah. And so this was actually everybody that went to EMS conference in Texas this last year, they actually had a booth. And it was capable soon of taking a first responder plus their bags and following a pre-programmed GPS course to a location and self-landing in the front yard. And so instead of taking your Tahoe or your F-150, you're going to hop in your drone and you're going to fly out to the scene. I don't
That's
know about
amazing.
hover ambulances yet. I don't know, but
I think they're going to end up having first aid kits, either AEDs or maybe even blood products at major intersections. So you have like I-35 and 45. There's going to be drones there that deploy directly to the scene, and they can do, let's say it's a traffic accident. They'll do a 360 orbit, and you may have a firefighter, an EMT, or paramedic sitting there watching the video and telling crews what they're seeing. We've got a 3-car accident. Everybody appears to be out of the vehicle. Everybody looks okay. We need the number 1 and number 2 lanes blocked. And I think you're
yeah, I
going to
think
see
you're
some
right.
incident command stuff like that. They already have the airways for IFR flights for if you can't see in the fog for planes. I think drones they will have drone highways for
Mhm.
the Amazon delivery drones, and then there'll be a designated EMS or medical type airway or something so that we can get Jetson One or whatever the drone is with the medic. Yeah.
Yeah, I think you're exactly right. It's going to be a neat time, and that combined with advances in vehicle safety things, it's just we'll be living in a more interesting world in 10 years.
What do you think about the self-driving cars? Do you think those are a good thing or bad thing for EMS?
Well, in today's world or in the
Well,
10-year world,
within 10 years, where do you think we'll be with self-driving cars?
I think that's really going to happen. I think the part that I don't understand, because obviously they're functioning today.
Yeah.
And it's funny if you go into downtown Austin and there's a Waymo standoff going on where none of them can decide who's going next. But that technology will undoubtedly get better. And I think in 10 years, it will probably be close to perfected, which I think will be interesting. The piece that I don't understand is just like folks today that love their legacy muscle car, right? Their Barracuda or their old Camaro or whatever that is. By all practical standards, should those things still be on the road today? Well, if we took a total practical approach, I'm not against it, by the way, no, but those things should be mothballed and in museums, right? For more fuel efficient, safer, right? So the question I have is, at what point are people not going to have the option to drive their car anymore versus the autonomous cars? Or at what point I think this would be a really nice hybridization of vehicles that you can still self-drive, but the automatic protective measures are so good that they will stop you and take over before you can get into a rear-end collision. And again, I know that exists today, but like I do, it's far from perfect.
Yeah.
But I think in 10 years, it'll be pretty close to perfect. So,
Yeah, I'm in favor of self-driving cars. I know it's a little hard to give up control, but if I look at the fact that like we have people out there with 6 and 7 DUIs and how many people have they hurt versus
sure.
an AI car with a hive mind, if they have that Waymo standoff where you're like which one goes first, eventually they're going to program that out of it so it doesn't happen again.
Right.
And of course, there's a flip side that hijackers could say, well, now the hive mind, everybody, Waymo's run everybody over, or the AI self-driving
What
cars
was the
eat pedestrians.
What was the old movie? It had Emilio Estevez in it where all the cars turned bad and they were at the truck stop. Do you remember that one?
I don't remember that one. Gonna have to find it.
Yeah, yeah. I'm gonna have to Google that one in the background while we continue to talk. But that's basically what it was, is all the cars and all the machine things turned against the humans and tried to kill them.
Uh,
So but maybe that won't really happen.
we could go down a whole AI rabbit hole with that one, but with AI and its good and bad points. Like everything, there's a good side and a bad side.
Maximum Overdrive, 1986.
Okay. That
Sci-fi
may be
horror
in
movie.
I may have
Yeah.
to look that one up. Yeah. And rewatch Terminator.
Everybody under the age of 40 is going to be really upset about the graphics, but just remember it was 1986. So
Yeah. Yeah. Well, as we kind of wrap up, how do we make EMS even better? I think we're really good, but you're a medical director. You see a lot of good things and bad things. How do we make this better?
The gosh, and I don't want to get in trouble here, right? So we've already covered this. I'm a paramedic and a firefighter, right? And I love being both. I hold them both in high regard. The jobs are very different, right? The jobs are significantly different. Now, granted, all of our fire folks out there, unless you have a dream job somehow, you're running 80% medical. And we know that. But when I look at our two disciplines comparatively, the fire service over its history of more than a century now, since the first fire got water dumped on it. I don't know what caveman did that, but the fire service has built in a lot of things that I think we need to try and emulate, and some that we don't. One is that the fire service has adapted to become an all hazards response agency, right? And I think we're growing into that, right?
Mm-hmm.
By understanding our emergency piece, our community piece, our prevention piece, our care at home piece. I mean, that will be our version of the fire service going from just suppression to hazmat to tech rescue to all that stuff, right? And so I think that's happening. It's just not happening super quickly. But then the other piece that offers a lot in the fire service is if you get into a good organization, you can be assured that if you work hard, that there's a progression, a career ladder progression for you. And I think that's challenging for EMS as we're designed today. And so I think the challenge of what I want for us is I want for us to be able to figure out how to build layers into emergency medical care where you can spend 20 years. I'm at Wilco today, and this is a shameless plug, right? Wilco, along with all my other EMS agencies, are wonderful, but you can come spend a career here, and there's a ladder for you to climb. But in a lot of places, unless you're the shift leader or the director, you're on an ambulance every day, all day, you and your partner getting torn up pretty bad. So I want that for us. I really do. I think that's important. What does that look like? I don't know. I'll say something controversial. Should EMS be a 4-year degree like it is in other countries? Whoa, maybe. But like anything else, what do you get for that? So better pay is certainly part of that. If we can allow people to come into the industry making $75,000 a year, and after 20 years leave the industry making $150,000 a year, that's reasonable. It's reasonable to get your degree, and maybe that helps you move up the ladder. I don't know, but I want EMS providers to be able to get into the pipeline as young EMS providers and spend 20 years and get out the other end with their sanity intact, their back intact, and a good financial situation to retire out of the industry on. So the medicine's going to come. I think the medicine is just going to take care of itself with good industry leaders and forward looking. I'm not really worried about the medicine. It's more our career construction.
Yeah, I think you did a couple things. One is like nurses are already good at this, right? You can go get an RN, you can work in a school handing out frozen sponges all day, theoretically,
Sure.
right? And again, I'll probably get some clap back for that, but the nurse handed out frozen sponges at my school.
You will, yeah.
But
here, dear.
You did this upward thing where we're starting small and growing big. And I think maybe that is part of the solution is going and getting a bachelor's degree in EMS may give you more opportunities to do that pre-hospital medical services that we talked about. Maybe you're doing some of the home health. Maybe you're doing research. Maybe you're helping people like some of the other pre-hospital courses that are out there.
And then one of the big ticket items to your point, Matt, I'm sorry, I didn't mean to interrupt, but reimbursement has got to get tied to this somewhere.
Yeah.
So and I don't know what this looks like. I have no idea. I'm not a policy person, right? But there's got to be a difference. If you have a super high functioning EMS system where you utilize National Registry trained people, APPs, your medical direction team is board certified, and X amount. This is kind of like the legacy or the magnet programs with nursing in hospitals, right?
Mm-hmm.
If X amount of your team has got an associate's degree or a bachelor's or whatever, then your reimbursement rate needs to be higher because your quality is bound to be better. And so I don't know, the funding model has to support it at some level, or else the incentives just aren't there. You know what I mean?
Yeah, absolutely. That's a really important component. I'm glad you mentioned that. So as we wrap up, I know that most medical directors are not active on social media, and I'm not sure that you are, but if people want to get in touch with you or maybe come work for one of your agencies, how can they get connected?
Well, yes, I am not as good at the socials, and I'm not going to say that I really follow my Instagram account or anything else really closely. But if people want to this is kind of old school, but everybody can email me if they want to.
I
And
don't know
so,
if you want to give your email out on a podcast. You can, but you don't have to.
yeah, I don't know. I mean, I think your listeners have a way for you to reach out to you, right?
Yeah, there's an email associated with the podcast. Yeah.
Okay. Well, if they want to reach out, they can reach out. I'm sure we can connect the dots. But
Yeah, we've got a contact form on our website, emtsacademy.com. If you really need to get in touch with Dr. Ratcliff, fill that out and we'll see what we can do to get you connected.
and let's see. So let's see. The current work environment is Williamson County, Robertson County EMS, Marble Falls Area EMS, and Travis County Starflight and the Travis County ESTs, amongst our multiple wonderful first responders. So also, I'm sure there are contact pages through those organizations that if somebody really wants to get hold of me, they can reach out through those organizations too. So
Absolutely. They may also be able to search Williamson County EMS staff directory.
mhm,
Yeah. So,
for sure.
well, Dr. Ratcliff, so thank you so much. I would say that you brought your A game to this, so I really appreciate it.
Did I do better than Dr. Jarvis?
We'll stop recording and then we can talk
Okay.
about
Yeah, we'll
that.
talk about that afterward. Well, Matt, thank you for the opportunity. I hope a few folks got something out of this today, and you're doing great work.
Well, thank you. I appreciate it. And if you're an EMT or paramedic out there and you're looking for a good place to work, Texas is truly amazing. We have great medical directors like Dr. Ratcliff, Dr. Jarvis, and a whole bunch of other ones. And it really is, to me, I've worked in Illinois, Texas, and Alaska, and it truly is one of the best places to work. So if you're looking for employment, check out our job page. We have some job postings and an email that goes out, and you can come work for a great agency like Williamson County EMS.
That's right. Let's go.
All right. Well, thank you very much. If you'd like